So today what I'm hoping to do is give an overview of my project, and really it's a worked up example of how I've used Discovery over the last 18 months, and I'm going to hopefully leave some time towards the end for questions. So this is actually a very timely presentation. Tomorrow is World Sepsis Day, and the presentation today is about sepsis, and my background is an intensive care nurse. So this is an area very close to my heart. So I'm sure everyone in the room has heard the word sepsis. I'm going to spend just a little bit of time really thinking about what sepsis is, because I think it is important to understand that in order to contextualise the project that I'm doing. So sepsis is a life-threatening and a life-altering condition. It is essentially the body's dysregulated response to infection. And this dysregulated response to infection can cause damage to our organs, our brain, our heart, our lungs, our kidneys. And it can cause damage, failure, and unfortunately for some people it can ultimately lead to death. And it's a massive global problem. The Lancet Commission estimates that there's about 40 to 50 million incident cases of sepsis each year internationally. And it leads to about 11 million deaths. Now, sepsis doesn't discriminate. However, there are some people who are more vulnerable. So very young, paediatrics, sepsis is a huge issue. The other end of the spectrum, older adults, are very vulnerable to sepsis. And also people who are pregnant or have recently had a baby, because of that altered immune function, can be susceptible to sepsis. Here in the UK, we know there's about 45,000 deaths per year due to sepsis. And it's thought to cost our healthcare system about £1 billion in diagnosis and treatment. But interestingly, it costs our social care system much, much more. It's thought, a recent estimate put the cost of social care related to sepsis at about £10 billion per year in the UK. So why is this? And that's because of the long-term consequences of sepsis. And I'm going to spend a little bit of time on this because I'm very passionate about it, and I think it's a message everyone should hear. But also this is really important in terms of the context of this project and why Discovery was the absolute perfect home for this project. So people following a sepsis diagnosis and during recovery from sepsis can have really significant physical problems. Muscle weakness, chronic pain, balance problems. And unfortunately, because of the kind of physiology behind sepsis and indeed the treatment pathways of sepsis, many patients will require amputation. It's not uncommon. We had an event last week in Homerton, and people came along, and there was people who had lost limbs as a direct result of sepsis. People, as you can imagine, have real emotional issues following a diagnosis of sepsis. There's the anxiety, is this going to happen to me again? How am I going to cope with this life-altering experience? Post-traumatic stress is common, thinking back to what is sometimes a very traumatic experience. Cognition is also an issue in this group. We know that executive functioning can be a real challenge, finding the words to put in sentences. Hugely challenging. And this mix of physical, social, emotional problems can all lead to real social problems. We know for those who need intensive care, only 50% will return to work in the year following hospital discharge. So for the people that were working before coming in to intensive care due to sepsis, only half of them will be back at work in a year's time. We know there's ongoing financial problems. We know this can affect families. Family members quite often have to take on caregiving roles. All of this can also affect our healthcare system. Evidence shows that about 30% of sepsis survivors will need a hospital readmission in the 90 days following sepsis. So 30% of them will end up back in a hospital bed. Now you can imagine the individual impact that that has on patients, their families, but that's also something that our healthcare system can't sustain. in terms of that utilisation. So I was really fortunate in 2019 to be awarded this Institute postdoctoral fellowship to specifically look at the recovery trajectory of sepsis survivors, to understand it and to think deeply about how we could potentially improve things for this patient group and their family members. It's amazing when you look back at what you thought you were going to do for a project. These were my original aims for this fellowship, and just to say that it was very much influenced by the COVID pandemic. So the first part of this was I looked deeply at the outcomes, what the recovery trajectory was for sepsis survivors. And we used nationally held data, we used data from the UK Biobank to do this. And we found that these patients had a really, really rocky year after ICU and sepsis. And they were more likely to require government-funded welfare support, they had higher hospitalisation, and they went on to experience some really deep emotional and social issues. But I wanted to understand this more deeply. That was the numbers. I wanted to get under the skin of this. What was the experience of people working in the healthcare system around looking after sepsis survivors? What was it really like for patients and family members? What did these numbers mean? And so, round about the same time as I was thinking through this, I was introduced to Discovery. And Discovery seemed the absolute perfect way to do this. Because I couldn't go to a normal hospital clinic or an ICU follow-up clinic. I wasn't able to do that because sepsis patients are all across our hospital system. They aren't in one area. I couldn't go to a heart failure clinic and ask to recruit patients to this, like you would for a cardiac drug trial. As I said right at the start, we have sepsis patients in care of the elderly wards, we have sepsis patients in general medical wards, we have sepsis patients in maternity. And I was really interested in this healthcare utilisation part, this readmission part. And what complicates things even more is people will go out the hospital system and they don't necessarily come back to the same hospital, they don't necessarily come back to the same ward, don't necessarily come back to the same treating clinician. So how was I going to capture these experiences? And so I think it was Jordan came and gave us a presentation on Discovery, and I think I chased you down, I think it's fair to say. And I was really humbled that I got the opportunity to work with the Discovery team to undertake this project as one of the fellows. And I really like this system map from the NHS England, but when you look at that, you can see that sepsis survivors can be in every part of our hospital system. So after working, and one of the things that I've really valued over the last couple of years is getting to work with people like Jordan and really learn from their expertise about what to do and how to do it. And so Jordan and I worked together and we decided we were going to do two different aspects to this project, a survey and interviews with people who had experience of sepsis and were part of that recovery trajectory. We decided we were going to look at three groups: clinicians, survivors, as well as family members and carers with this, because we wanted to understand all experiences of the system. The survey was a fairly, a fairly meaty survey, in that we wanted people to, answer quite a lot, and each survey took between 20 and 25 minutes. So it was a big task that we were asking people to undertake with this. And then we specifically wanted to look at people with that experience of readmission across our hospital system. Partnerships were absolutely key, and so that's really the title of this presentation. And partnerships at all parts of this process were hugely important. I was really privileged to work with a charity called Sepsis Research Feet. There's not many sepsis charities in the UK, but this is one of the bigger ones, and they became our public partners with this project along with Discovery. We worked with many professional organisations in order to disseminate this work, but the main one was the Intensive Care Society, who came on as partners with us. And we chose the Intensive Care Society because they have a huge sepsis working group, and they also have lots of professional working groups. So we were able to really get that survey out far and wide. So we were delighted with the response. We had almost 250 responses to that initial survey, and I was particularly delighted that the majority of them were actually survivors that completed that survey. Our clinicians were from far and wide. We had clinicians from community, we had clinicians from the acute part of the hospital, we had maternity clinicians, we had social work, we had community organisations, a real diversity in response to this, which was fantastic when we were really trying to understand how we could improve things, essentially. And then we went on to undertake 53 interviews across our 3 groups. So what have I valued most about using Discovery and certainly working with the team over the last 18 months or so? Well, the first thing is about the accessibility of this platform for me. So as I said at the start, many of our patients have significant and substantial ongoing issues, be it able to access research generally, but actually access platforms. And this provided a hugely accessible format for people to use it. And what patients have fed back is it was a one-stop shop for the research. So they came onto the platform, they could sign a consent form, and that consent form was easy to complete, and then that carried through. And as a researcher, I don't think you can underestimate how much of an impact that has for patients. And an example this week is I'm working on a publication with a patient, and we've had it accepted, and the patient has to sign a conflict of interest statement. They then have to sign a PDF, they have to scan the PDF and then upload the PDF. This is a sepsis survivor. Now, we've had a lot of fun, myself and this particular sepsis survivor, trying to make this work. But that has actually been a huge amount of time for that person. And the ability to go in and do this once and do it well and do it in a rigorous way has been really, really important for this project. I'm going to be really selfish and say from a researcher's point of view, it has been really fantastic to have that integrated platform, again, where all of the governance is in the back of this, where we know we're safeguarding patients, the governance is in place, everything's on that platform for people to access. And for people that work with me in this room, you will surely attest that my organisational skills are not top-notch. So the fact that you can link a diary so that people can just make appointments with you for those interviews has been a game changer for me, I have to say. And I think I have to end on the diversity and inclusivity of the participants that took part in this. We had clinicians as far away as Africa take part in this survey, and we had real diversity in the patient cohort that took part in both our survey and our interview, which has been really humbling, actually. I've not got much more to say about the platform and the process that I've undertaken, but I'm going to leave you with one thing, and I think this is really testament to the platform. I'm already planning my next project. We have got a core outcome measure set starting, or the development of a core outcome measure set and some consensus building starting later this year, coming out of this project specifically about family members. And I think that's because I'm confident that we'll be able to engage people, that people will be able to access this platform in a really effective way. Thank you.
To ask Jo some questions now, if anybody has anything they'd like to ask.
Thank you very much, Jo. Sorry, not to go from the confirmation. Can you say a little bit more how you use the platform? Your platform is obviously digital, inclusivity, digital access. How's that something you addressed through your project?
So one of the things with the platform which is great is that you can go to a telephone only or a non-digital approach as well, and we built that into our ethics from the start. The only thing that we had was people forgetting their passwords, believe it or not. I forgot my passwords, and quite often they'd registered with a different email address. But again, you have the technical support from Discovery where you were able to kind of to sort that out. there is an element of digital literacy here that is required to do that. But certainly we collected postcode data on our patient group, and we had a real variation in terms of geographical spread for both the patients and the clinicians that were involved. So from that, it's far from perfect, but there is a diversity in people in terms of geography, in terms of ethnic background, who were able to participate in this. Heidi.
I'm Dr. Tanya Lam from Greece. I'm just curious, how did you decide to select the patients for the survey?
For the survey. So the survey went out through our patient charity partners. So they put it out to, they've got a huge mailing list that they were able to put that survey out to. And it was people who wanted to complete the survey did that. In terms of the interviews, how we selected participants for the interview was, I was particularly interested in readmission because I think speaking to patients don't want to be in a hospital setting. So part of the project was, is there anything we can do from a healthcare improvement perspective to make this a more effective process? So we were, as part of the survey, we looked at who had been readmitted, and from that we were able to really think about who we wanted to interview from the sample.
Oh, there's two. Adam, do you want to go and then Jenny?
Yeah, I'm Adam from University Hospitals.
Hiya.
I'm just interested in the recruitment question as well. So you went through a charity that's got a registered list of patients with cancer centres. One of the things that we're looking at is how can we use our data to support control and research recruitment, hone in on very specific cohorts of patients. So do you think your research would be different if you recruited based on real world data around everyone's consensus in a trust or multiple trust, as opposed to going through the charity?
Yeah. So I think there's probably two sides to that coin. So I think absolutely the data would have been different, but it would have been, what we didn't have was an ICU data about what actually their experience was, and so that's a limitation of our study. But by the same token, we were able to go out to a much bigger and more diverse group than you would ever get in a single hospital system. And I think the challenge, as I said, with sepsis is there's no part of the hospital that you can say I'm going to recruit. Now you could have perhaps come up with these are all the patients, but I suppose it's that point, it's the consent and the follow-up to that. So I think there's both pros and cons to here's a set group of patients, we've got them very well characterised, and now we're going to try and unpick this, versus let's try and get experiences from very diverse, different and geographically spread groups.
Jenny?
I was just wondering what you learned about patient experience from people living with sepsis, and you partially answered this, but what difference do you think it made using the Discovery platform in terms of the insights that you gained?
So in terms of what I learned about patient experience, watch this space in terms of what will come out. We've seen these issues again from a patient experience point of view, but what we really learned was about transitions of care actually, and how these people move across the hospital system, and that's really where the fracture points seem to be for this group. So that's one, and really that idea about treatment burden. These patients can go on to experience, they have ongoing care needs, but the care needs aren't necessarily linked up together, and they might be seeing a respiratory consultant, they might be seeing someone specialising in their diabetes as well as the rehab specialist, and that can be overwhelming for patients to navigate. So those have been two of the big things that came out. In terms of the kind of user experience that we've had, I mean, if I'm being honest, patients have just came on, it's worked, and then they've went off. Again, and for me that actually is a singing endorsement that there's not been problems, they've just came on, it's worked, and then they've said, let me know about the outcomes of this research. I actually managed to see one of the, it was said as a coincidence, I actually met one of the people that had interviewed in person last week. And she was very complimentary. She was like, oh yeah, you were on the system that was pink. She said to me, and I said, that's the one, that was me. And she was like, oh, that was great. We've got to learn more about it. So I I think when something works, you don't necessarily get lots of feedback about it. It just works smoothly, I think, is my experience.
So we've just got a little bit more time, so we'll have Doug next, because I think and then Francesca, and then I think we might have to leave it.
But would you mind also repeating people's questions so I've got some context for the answers, please?
Absolutely.
I can do that, that's fine.
Doug.
Thanks, Jo. Joe Galvani at Discovery Board. You hinted at it, but I wonder if you've got any feel for the efficiency, if you like, of using the Discovery platform. What resource implications have you had to pursue if you hadn't had this platform to do the same study without it?
So that question was really around kind of the resource implication of using Discovery and really thinking about if there was the effectiveness of using it. For me, it made the process very streamlined. So there's almost project management built into Discovery, and that it's an integrated research system. So from on the platform, you have the patient information sheet, you have the consent form. It's all there and it's completed by the patient, and you can check that that's all done. That saves a huge amount of time for a researcher, even just sitting, doing virtual interviews. You don't have to go line by line through the consent form. There's also quite often you have to get patients to, the digitalisation of consent forms isn't always 100% either. So that front end part of it certainly saved a huge amount of time. But there's also the kind of process at the end, and using Qualtrics, for example, that the data's there, it's accessible straight away, and you can really get your sleeves rolled up and use it. And so that, in terms of timelines for research projects, especially when you're on a grant and you've got to get it done in 2 years, that helps a lot, that data's there ready to use and ready to get cracking. So for me, the big bit was the organisation and that project management side of things, but also the ability to access the data very quickly was a big selling point for me.
Yeah, thank you for your talk. I was wondering, thinking about your next steps, do you kind of envisage coming back to the platform again to think about how to apply your findings and think about what implications it might have for policy and practice, and is that something you're able to do within this?
Yeah, so I have got big ideas, as you can imagine. So repeat the question, sorry. So this question was around what next for the project and how might I use the Discovery. So one of the things that's came out of the interviews is the need to support family members better. And anything that we do going forward, family members, carers, informal carers, loved ones have to be involved. At the minute, we haven't really got a good understanding of what good looks like for that family group. So the first thing we're going to do is actually this next project, which is around understanding outcomes for family members, and we're going to use the platform for that. So that's the first step. The next step is really about looking at what would a model of care look like for this patient group that would be acceptable, feasible and effective within our NHS. Again, I would love to do some consensus building round about that and some co-production, and Discovery absolutely gives the platform to do that.
Thank you so much, Jo. Round of applause.